Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday edition. It's my great pleasure and privilege to welcome our speaker for tonight, Dr. Marc Bloomenstein. He's a graduate of New England College of Optometry, and he finished a residency in secondary ophthalmic care at Barnett Delaney Eye Center in Phoenix, Arizona. He's also a fellow of the American Academy of Optometry. He is currently Director of Optometric Services at the Schwartz Laser Eye Center in Scottsdale, Arizona, and President of MRB Eye Consultants. He's on the editorial board of numerous journals. He served as the chairman of the AOA Continuing Education Committee and served on the board of the Ocular Surface Society of Optometry. He has done numerous lectures across the nation and across other countries. We're very fortunate to have his insight and wisdom and experience. So with that, please give us a nice warm virtual welcome for Dr. Marc Bloomenstein.
Well, thank you for that kind introduction. That was lovely. Appreciate it. Hopefully everybody can hear me. Greg, can you guys hear me? Joe, hear me okay?
Yes.
Yep, you're good.
Very good.
Awesome. There we go. So, interesting enough, when I titled this this lecture, I was kind of thinking along the lines of things that we seem to just always do. Seems that, kind of like, why do we still use a phoropter? Well, because we've always done that. Why do we sleep on our left side? Because I've always done that. As optometrists, I feel like, this Hackneyed, or basically things that are trite, or things that you just kind of are old things that we've always done. And to me, one of the things that makes our profession so fantastic is the notion that we can actually incorporate quite easily new technology, new ways of looking at things. So the intent tonight really is to kind of get us to start thinking about new things and how we can integrate them into the practice. Some things coming down the line, but more importantly, it's just kind of in line with what we do as a profession. So this is me, speaker panel, consultant for some different companies. It pales in comparison to your two hosts, but I'm scrappy, trying to get out there. Okay, more importantly, past president, optometric counselor in refractive technology, but I do have some stock in one thing, and that's Starbucks. So if you have not gotten your pumpkin spice yet, hook yourselves up. That stock isn't going anywhere. You know what I'm saying? So let's get into this here for a second. So one of the things that I always kind of find really exciting is when a drug company comes out with a new drop. Now, sometimes they're just repurposed drops. Sometimes they're old drops that they basically just, have given new life. But the truth of the matter is that they always kind of seem to find a place for us, and they should find a place in your practice. And I'm always kind of taken aback, and oftentimes, I'll have interns. I used to have students. I used to have like residents and students, and when I was going through the ranks, I was really abused. The preceptor I had was quite abusive, and I realized that the abused become the abusers, because literally whenever I would have an intern or a student there, I acted in the exact same manner. I mean, for me, it was literally I felt my job was to break these kids down and just let somebody else build them up. I mean, literally, it's like bringing them into the lane and saying, what do you think that is? And if you guess, I will fail you on the spot. Okay, that's what I thought. But I was always taken aback by the fact that in school, they're still taught things that I was taught 25 years ago. I mean, graduating from Nuenco in 1994, to hear them say, well, I would consider pressure patching. Pressure patching. Has anybody, when is the last time any one of you have put a pressure, I mean, even then, what were we pressure patching for? It made no sense whatsoever. Take a little tape, do a little T-tape, but we have better ways and better approaches to manage a lot of these conditions that we used to look at and kind of like treat and manage differently. Like, for example, artificial tears. I mean, to me, an artificial tear is tantamount to nothing more than a mint. And I will say this until the day I die. Most of my patients could use a mint. I'm just saying. Now, I mean specifically for their breath, but I also mean for their eyes. And I think most of you will agree with me. When you look at somebody in the slit lamp, you look at the quality of their ocular surface or look at their tears, then the quality is just, it's no bueno. Um, and one of the main reasons why is because of the things that we've been doing these last few years, and it's cray cray. I mean, I don't know if you guys are with me, but it's just like when people say, "Oh, when did you do that?" I'm like, "Oh, a couple of years ago." No, we lost a couple of years. Nothing's happened in these last 2 years. 2020, 2021, which is almost over, these are years you're never going to get back. And so to me, when I look at a patient and realize that they've been doing the same thing I have, I'm binging like mofos. I haven't seen the Squid Game, but I guarantee you that the vast majority of you have watched the Squid Game. Yellowstone's coming out. I can't wait to watch that again. We're watching The West Wing again. It doesn't matter. We can keep going. And so what our patients are doing differently with their eyes means that the quality of their tears is suffering. And what also means is that they probably could be using mints. To me, an artificial tear is tantamount to putting a mint in your mouth that stays there for a few minutes. And then you're like, oh, could I use another mint? And when we're talking mints, we're talking Coca-Cola flavored Tic Tacs. Yeah, that's a real thing. But we have new drops now, especially in and around the ocular surface. We have some other drops to help with another burgeoning nouveau thing that optometrists really should be getting excited about, and that's, aesthetics. Some people call it aesthetics, aesthetics. I call it aesthetics because it's for the eyes. So let's talk about some of these. First and foremost, which came out in January of this year, believe it or not, was a drop called Isuvis. Now, some of you, I believe, are probably using it. Some of you probably have tried it. Some of you don't even know what I'm talking about, and that's cool. But Isuvis is another version of loteprednol tabinate. So that's almost like that Hackneyed, that trite, kind of oldie way of managing things, but it's an ophthalmic suspension of 0.25%. It's one of the lowest concentrations of loteprednol tabinate we have, but here's the rub. Cala Pharmaceuticals has this drop indicated for short-term up to 2-week treatment of signs and symptoms of dry eye disease. Now, I just spent a couple minutes telling you that I feel that what we've done to our eyes in the last few years is probably going to affect us for a long time. It's going to affect everybody. I mean, I think everything that's happened these last few years is going to affect our psyche. It's going to affect our mentality. I think I've lost more hair. But if you think about this new concept of a transient or episodic dry eye, having the ability to have a anti-inflammatory, a steroid. Now, this is not, I'm not advocating that we're not going to still use, for our chronic dry eye patients, because we have those, whether it be cyclosporin or lifitegrast. What I'm basically saying is that we now have an opportunity to say, look, you're having some problems. So now we have an ability to help you for that short period of time so you can get back on track again. And think about it. Think about all of you guys out there, okay? How many of you have prescribed, maybe today, you wrote a prescription for a combo drop, a 0.3% tobramycin with some version of a dexamethasone or some version of a loteprednol, whether it be generic or whether it be on label, Tobradex ST or Tobradex, or whether it be Xylet. You have. I'm looking right at you. You. Yeah, I'm looking at you. And you know what? I'm right there with you. You see a little inflammation, you see a little teary, you have a patient who's fetching a little bit, or maybe they just, their glands look like crap. You want them to feel better. Is it the 0.3%? Is it really the tobramycin that's making the difference? No, it's a steroid, and we all know it. And then 4 months down the line, maybe the same exact time next year, it was 66 degrees here today in Arizona. Okay, when I left, as Greg said, to go to North Carolina, it was 93 degrees. From 93 to 66, you know what happens? The weather changes really, really bad. And what happens when it changes? Patients' eyes get all jacked up. People start getting, allergy symptoms, but they also start feeling swollen and inflamed, and the dryness gets worse. They don't call it dry eye though. And so we prescribe those combo drops, and then they call us and they're like, come on, man, I just need some more. come on, hook me up, hook me up. And you know what I am? I'm like, I'll hook you up. Go, bye, be done. I don't care. Because why? Because I know the steroid is going to make them feel better. When we think about this disease state, which I don't really like to call dry eye, because I don't really think, I reserve the word dry for those patients that are like hella dry. Like, they can barely open their eyes. It hurts like a mofo. They can't read. They can't. The patients that have early signs of this disease state, if you say your eyes are dry, they're going to say, no, yeah, I don't think so. No, I'm good. And I'm like, no, you really are. No, I just don't. Because the word dry is so confusing for patients. But there were studies that were done that basically went into Beaver Dam, Wisconsin. They found the prevalence of dry eye in that population was about 14.5% in the 1970s. Well, panel vans, water beds, not really sure why water beds, don't even know what you would do in a water bed. What they do, they had kids. They went back in 2005 to 2008 and they did an epidemiological study of the kids, the progeny. And what they found is that the prevalence of dry patients there is literally almost exactly the same, 14.5%. What? Yes, 14.5%. But what happened in 2006? I'll tell you what happened. The iPhone 13, don't be jelly people. Yeah, iPhone 13. The iPhone was invented in 2006 and everything changed. And so those numbers you see there from 2005 to 2012, the prevalence has increased because we're not blinking. We're not doing the same things. Kids are not going outside and playing. You know what? I can think of Caldwell in rural PA running around playing football, looking like Tom Cruise in whatever that movie was when he was in high school. No, now they're inside playing Madden or, killing people on their computer. And so that prevalence changed. And here's the caveat, my friends. The adults were average age 40. The kids were average age 20. So this is a disease state that is starting sooner, but it's not chronic yet. It's transient. It's me sitting here and watching both seasons of The Mandalorian in 2 nights. Boom, that happened. You heard that Greg said that I'm flying out tomorrow at 5:15 in the morning to go to Chicago to go to Sarasota. And then I have to wake up at the crack to get to Colorado. These ojos are going to be no bueno. We're talking about this kind of this episodic dry eye, this transient nature of it. And what does that look like? Well, our patient's eyes look inflamed. Get the hyperemia, the redness, the glossiness to it. They get some staining. But the other thing too is they feel uncomfortable. They don't stay on the computer as comfortably. Or maybe when they're driving home, they're like, I'm getting a little glare, a little halo around the lights because of this inflammation that's affecting their vision. And it's 2 seconds here. I think I have a video. I'm hoping it'll play. And I did see there was a question there, and I will get to it. I promise you. But when we think of the eyes, they're no different than any other inflammatory feature, right? Whether it be like patients that get asthma or get uveitis. We all have these patients. Well, I can't say you all. Well, we all, most of us do, where we just have this person who comes in with this chronic iritis. We treat it, it gets better. Or those patients where you'll see some Seneca and you're like, oh, you've had this reaction before. The eye contains the same type of lymph tissue. It has the same diverse microbiome. So we get these flares. And I'm trying to remember, there's a commercial I keep seeing for God, I don't know what condition. Maybe it's for colitis or something on AMC, where it's like, if you get, colitis flares, but flares for the eyes. Okay, here we go. Let's hope this plays. Let me know if this plays.
Although dry eye is a chronic inflammatory disease, the majority of dry eye patients experience episodic exacerbations of signs and symptoms or dry eye flares in response to various triggers. An acute flare begins with an innate immune response that can lead to activation of the adaptive immune response. Initial inflammatory response starts when epithelial cells respond to environmental stresses, produce inflammatory mediators, and create a cytokine storm involving IL-1, IL-6, IL-8, TNF-alpha, and matrix metalloproteinases, which intensifies the immune response. This cytokine storm can attract inflammatory cells, which may cause conjunctival redness and perpetuate dry eye flares. Antigen-presenting cells migrate to the lymph nodes, where they involve T cells and the adaptive immune response. Activated CD4-positive T cells can differentiate into T helper cells. These infiltrate the ocular surface and secrete pro-inflammatory factors like interferon gamma and IL-17 that further promote inflammation and cause damage to ocular tissues. A flare can also occur in chronic dry eye, where antibodies and inflammatory cells are already present, which lowers the threshold for an adaptive immune response. This can make the response more severe and longer lasting.
So, bottom line, what we're saying here is that we need to treat these flares at the source to try to quell that cytokine storm so that it doesn't create this adaptive into this innate immunity. A lot of the patients I think that we've been treating is that we didn't start doing things soon enough. We didn't control these T helper cells. And then by putting them on cyclosporin and putting them on lifitegrast, it was almost too late. These drugs work together. And to me, what's nice about this is that we do have our patients who are on a typical journey of contact lenses or, seasonal allergies, cold air, digital screen time. As the winter time's coming, especially on the East Coast, unless you're in Miami or Sarasota, or if you're in Florida, there is no winter. Right? It's all steamy weather. I mean, we get these triggers, and especially for our patients. To me, what's nice about having a drop available like this is that I can sit there and say to my patients, these patients who I know are going to suffer flares. They did like 3 major studies, lots of patients, and they found that about 80% of patients actually only suffer flares. 45% of patients only get flares. And so these are patients that are not coming into the practice. These are patients that are going to the grocery store and picking up tears. These are the patients that are coming to your practice and saying, what do you think about some BBCGs? And you're going, well, it depends. Are you talking about the blue blocking computer glasses that you see online at late night? Because if you are, I have to ask you a quick question. Are you single? Because if you're single, then you should not get them, because you will stay single, because those are hideous, okay? Those yellow lenses, besides the fact that they don't do anything for screen time or discomfort, maybe they might do something for the circadian rhythm, but they're not doing anything to help with any comfort. All they're going to do is when you roll up on some hottie in your office and you go, hey, they're going to be like, okay, yeah. So those are better served in the basement of your parents' home. That's what I tell my patients. To me, if they're asking you about that, then they're saying, hey, I think I might need some help while I'm at the computer, while I'm doing more screen time, or while I'm wearing my contacts, or maybe even better yet, to preemptive manage the eye before they go in for cataract surgery or refractive surgery. Now, normally what I would do is I would drop a little M&M on you and basically say, yo, everybody from the 303, put your hands up and follow me. Everybody from right? I think it's the 303. And literally, what did Eminem do? Eminem basically said, yeah, I know you're going to say that I live with my mama in a trailer park. And I know that somebody is going to say to me, but Marc, we're talking roids. We're talking steroids. Are you for serious about putting somebody on a steroid? Because the two things that when we think about, well, maybe there's 3. Some of you might think about herpes, and that's cool. Okay. You didn't want to put that in the comment section. I got you. Okay. Is that, and I look at steroids as being like Will Ferrell during Blades of Glory. They're provocative, just like the song that they were going to skate to. One song and one song only, My Humps by Fergie. Is that literally putting a person on a steroid, you're following them. If they get a herpetic infection, isn't it better that it happened with you kind of in the mix? I'm just saying. But yeah, the 2 things that we always worry about are, 1 is increase in pressure, and 2, you worry about cataracts. I've been practicing for 25 years. Juice, 27 years. Oh my God. I have never, ever seen a patient who has developed a cataract from a topical steroid. Now, does it mean it couldn't happen? Sure. But could it happen with a 0.25% ester-based steroid? One that I'm going to show you that basically has its highest concentration just in the cornea and never penetrates into the anterior chamber? I'm going to say it's pretty rare. Most of the patients that I have seen, and there was a study that was done in Bascom Palmer where they actually used Alrex, which is 0.2%. It was a 5-year retrospective study. Patients who used Alrex every day. Nobody developed cataract and nobody developed glaucoma. The thing about, when I think about cataracts is I'll have patients, well, I know they've been on steroids, and I'll just be all like, hey, I'm seeing a little cataract formation here. You sure you're not using steroids? And they're like, no, I'm not using steroids. And I'm like, Michelle, honey, are you sure? No, I'm not. Yeah, from, systemic steroids, I'll see it. When we certainly look here at our mindset and what should be this nouveau. So we got this Hackneyed mindset, this old way of thinking about that this is a chronic disease and the only thing we can do is put them on tiers and hope that they use it. Start every single patient on lifitegrast and as well as maybe a cyclosporin. But the vast majority of our patients who are younger patients now are getting this transient short-term problem. And more importantly, when we look back, we've only diagnosed half of those 35 million. And of that, 75% have never been on a prescription medication. I use this in and around my practice, mainly for 2 reasons. One is because I want them to have something to reach for. I don't want to prescribe Xylet or Tobradex ST if I don't see any bacterial conjunctivitis, which I usually don't. It's usually just okay, bye, here's a roid, it makes you feel happy. One of the questions also would be well, why not just use a generic loteprednol? And you can, but not all generics are the same, meaning that the molecule of the loteprednol may be the same. It's a different concentration, but the vehicle is what makes these unique. And so I think anytime a new drug comes out, you have to ask yourself, what's the vehicle? What's bringing it into the eye? With Isuvus, it's powered by what they call Amplify technology or some MPP. I'm down with some MPP, and this is a mucus penetrating particle. You know what? We have a video for that too. Oh, it's coming up. Okay, it's coming up. What I failed to tell you, and because somebody had asked it in the chat group, who asked it? Michael did. Thank you for asking, Michael. What he also said is about the pressure. And, I can't talk about pressure because, whenever there's somebody from the past president or president of the glaucoma societies on the line, it makes me a little nervous, but I will share with you this. Of all of the evaluations of every pressure they did in these robust studies, there was only 3 pressure readings, 2 of them that were greater than 21. So maybe they were 24, 25, nothing significant, and 1 pressure reading that was greater than 10 millimeters more than when they first came in their baseline. That accounted for 0.2% of all of the pressures taken. 99.8% of the pressures were within those parameters I just gave you, which is what the FDA looks at. So no elevation in pressure. The other thing is because of the Amplify, and I'm going to show you in a couple seconds here, is that the vast majority, there was 100-fold more concentration in the cornea than the anterior chamber. So literally what it does is it brings the drop to where it needs to be and it doesn't move on. That's Isuvus. How would this fit into your practice? Well, I'll let you guys decide. To me, it fits into my practice when basically I have a patient who comes in who's young, who's old, moderate, who's not getting enough relief from the chronic medication I have them on, or those ones that say, I made an appointment, but I feel like things are better. I had a couple days where it was a little hairy, and I'll basically say, I've got a drop for you. Cala also has something called Inveltus, and this was their first drop that came out. It's the only corticosteroid FDA approved for twice-a-day treatment, and it is for postoperative inflammation following pain after ocular surgery. This also uses the Amplify technology. This is just a newer way of basically, if you have patients that don't have a lot of good compliance, it's a 1% loteprednol tabinate. It is amplified, so you know it's going to get to the places where it needs to go. And if you want to know about the Amplify, let's watch a video.
Kala Pharmaceuticals has developed a proprietary technology, Amplify drug delivery technology, which utilizes mucus-penetrating particles. It is first being developed for eye care. Within the eye's tear film, the mucins play an important role in protecting the eye. Mucins trap and eliminate particulate matter such as allergens, bacteria, and viruses by adhering to them and rapidly clearing them with tears as the eyelid blinks. But in playing this pivotal role, mucins may also limit penetration of traditional suspension eye drops in the same way. Amplified drug delivery technology uses nanoparticles of active drug with a proprietary surface coating. This allows the drug to penetrate through the mucus barrier, allowing enhanced distribution and penetration to the ocular surface tissues, the conjunctiva, and cornea without being trapped and eliminated by the mucins. In fact, a preclinical study showed that amplified drug delivery technology was capable of delivering 3.6 times as much loteprednol etabinate to the cornea as an active comparator formulated without amplified drug delivery technology. Amplified drug delivery technology is a novel advance that is designed to allow more active drug to get to the target tissues.
Yes, the drug is fuchsia colored, so that's always kind of nice too. But I always think of the mucin as basically being that barrier, that gauzy barrier to stop the drugs from getting in there, which is why, a lot of the drugs that we see now that are being approved are basically, submicron. Lotemax SM. Lotemax SM, that's a 0.38% Lotemax gel. That was supposed to basically be called Lotemax AF. Yes, okay? You guys are getting a little marketing 101, my friends. So they were like Lotemax AF, and one of the marketing guys said to one of his kids walked by and saw that, and they're like, "That's awesome, AF." And he's like, "Well, I don't understand what you mean." He goes, "Just Google it, Dad." Googled AF, yeah. So they changed it to SM. So Lotemax basically is a submicron. So the whole point of it, making it tiny to traverse through there, they thought advanced formulation was going to be like the way to go. But yeah, I still think, I don't know, sadomasochism versus AF, I would have gone with the AF. We have a new medication that isn't necessarily something that we probably will be doing in our offices. In fact, never. I mean, unless you're doing infusions. But this is Tepeza. And why I think this is important from Horizon
Hey, Mark, let me
Pharmaceuticals.
do a
Yeah.
couple polls here, because I know what your polling
Wow.
questions were. So we need to kind of break your rhythm.
Oh, look, I like the second one.
Yeah, I got that fixed for you. So
Oh, and Mark, I have to correct you on something. You made a mention that we don't have winter here in Florida.
Yeah.
No, we do have winters here in Florida. In fact, 2 or 3 days last January, I had to wear socks to work for a couple of days.
There you go.
Hey,
That must
Mark,
have been tragic.
while this is rolling in on your, on the iSuvis, the point that, I'll just kind of sum up to keep the conversation going would be, there's mechanism of action, there's mechanism of delivery that's out there. So we've seen things like, Sequa come out, which is cyclosporin. They did change the concentration, but again, they did change the mechanism of delivery. So we see loteprednol. I see people when I do this talk and I tell people I'm using iSuvis, they're like, "Oh, it's just another loteprednol." Well, not really. I lecture with a pharmacist. Pharmacists geek out of mechanism of actions and mechanisms of delivery, and they're pretty, excited about, the mechanism of delivery changes that can occur. And this mechanism of delivery is created, allowed it to get down to 0.25% rather than 1%. So, it's just, not that you said it, but I can hear our colleagues out there, "Oh, it's just another loteprednol." Well, not really.
And I provided that awesome video. So
And you provided an awesome
know.
video. So there you go with your results, making this live and interactive.
Yeah. 1/3 of you thought I made that up. Au contraire, my friends. Au contraire. That is a real word. So yeah.
And then I'll launch this other one maybe at some point while you're talking. So go ahead.
Okay. So Tepeza, okay, some of you may have seen it if you watch, like, the Bravo television. I'm not saying I do, but Top Chef. Love that Top Chef. Tepeza basically is for TED, or that thyroid eye disease, which we all kind of like see in our practices. 80% of Graves patients have some ocular involvement. 15% basically will develop severe vision impairment. So TED basically is the eye-related component to that. Now, when we think about thyroid eye disease versus Graves' disease, the thyroid eye disease is basically the whole front and back of the eyes, whereas the Graves' disease is more just the thyroid. And it's basically affecting and then going to be kind of a secondary transmission that's going to affect the eyes. The muscle and the fat in and around the eye becomes swollen. It causes the proptosis, which in turn basically then causes the grittiness. Remember the old nose specs when we were in schools? That's a Hackneyed thing. Am I right? Yes, I'm right. Right? No signs, only signs, symptoms, proptosis. I can't remember the other ones were because I just don't do it. But literally you're talking redness, itching, burning, bulging, and literally other vision changes. Those are all eye-related conditions because of the Graves' disease or because of their hyperthyroidism. When we start looking at, perfect examples, we have that perfect example of that proptotic eye. Classic symptoms will be like Dalrymple sign or von Graf sign with that eyelid lag, the foreign body sensation, the blurring. For patients that have significant problems or significant symptoms, then this is a really good opportunity for them because, there are basically these receptors that are ignited, if you will, during the process of Graves' disease. And once one of these receptors turns on, it induces that swelling, causing the double vision. What Tepeza does is it basically blocks those receptors. It allows the muscle and fat tissue to regress, come back to its natural shape, and decreasing whether it be diplopia or proptosis. Now, this is a temporary relief. This is not going to be something that it's one and done, which is why these patients are going to be going through these infusions. It's given essentially their first infusion is then about every 3 weeks. It can last for about 6 months, as we see here. It says 5, but I've seen up to 6 months. So they basically have to go to a center where they're going to get an infusion. And I've actually talked to a couple internists who I've referred to. One of them went through with it. One of them didn't. They did really well, happy with it, but they weren't necessarily excited by the notion of the fact that 90 minutes for their first infusion and then for the first 2 infusions and then 60 minutes for the next 6. So I really do think that this is something that you can offer to your patients, talk to your patients, but just kind of keep it in the back of the mind. Okay. Now, I am a huge proponent of aesthetics. And some of you out there might be saying, okay, Mark, this is a new drop, but let's be real, okay? I'm not doing Botox. I don't do IPL. I'm not offering patients, Latisse, although you should. Because part of, I think, when patients feel that they're not doing as well is when their eyes don't look healthy. It's why they go to the pharmacies. It's why they feel like things, if they feel like they're looking tired. But, let's be honest, okay? I don't think this is going to be going away for a while. And what is it that most of our patients are looking at? It's these right here. And, I don't know what the ratio is of attendees here, males to females, but in optometry, it's probably like 2/3. 2/3 of graduating optometrists for the last probably decade have been females. And you guys know, I mean, right now the lashes being super long or going in for some microblading on the eyebrows, to me, upneek is something you should consider and think about in your practice. Now, they've changed their model. RVL now allows it where you can actually sell it in your practice to your patients. It used to be just that you call in a prescription, but I frankly like that. I like providing my patients with an opportunity to not only make their eyes look better, but also feel better. And so if I see somebody who's coming in with ptosis, or maybe even just a little bit of acquired blepharoptosis, then I'm going to talk to them about it. I'm going to show you some examples here because, you look at these 3 different examples, and the bottom one to me is I laugh inside every time. And the main reason why is because my wife will always say to me, do I look tired? They're like tired. And she's, oh, I feel like she's just, you know, how like when a patient wants to get a blepharoplasty, and what I'll tell them is like, you know, just go in like this for your visual field, and then just make sure you pop those eyes open. So I look at that bottom one, and it just feels like the person's like keeping their eyes closed, but they're not. So there's varying ways of looking at this, but none of this is really that important. And the reason why I say that is because none of us are going to go in and use field testing or levator muscle functioning or eyelid crease height. But what you can do is you can look at what's more common, which is the marginal reflex distance. And that basically is the distance between the center of the pupillary light reflex and the upper lid. And so to me, if you go back and you look at these patients, you can absolutely see the center, right? And then the lid, center and the lid. So you can really appreciate that mild, moderate, severe that we're going through here. And so the normal range is usually greater than 4 millimeters. And I am not advocating that you go in and measure these. I think just kind of getting, you know, a sense, because acquired ptosis basically has a range of severity. And as we get older, what you start to see here is that patients start to basically kind of get visual impairment, neck pain, they can get brow aches, because what's happening is the lids are basically starting to close. And so going in and looking at younger patients and just asking them a question like, you know, do you ever feel like your lids make you look sleepy, right? Or your patients that are using lash extensions or using Latisse, is asking them, do you feel like, you know, you'd like to have your lids pop open a little bit? For patients that need blepharoplasties, this might not work as well, but here in Arizona, we are not getting blepharoplasties done for about 3 months, maybe 4 months. They can't even get in for a consult till February or March. God, that's 5 months. So literally, what I'm doing is talking to patients, and I think some of these centers are too, about starting patients on Upneeq. Upneeq basically is oxymetazoline, which is an alpha adrenergic agonist. And much like some of the other drops that we use, you know, these alpha adrenergic agonists really work well on the smooth muscle. It works on Muller's muscle. And I always kind of describe it to patients as kind of like, you know, if I came in and scared you, right? You might pee a little bit, your eyes will bulge open, your pupils will dilate, right? And that's that fight and flight. Well, literally what we're doing is we're just kind of activating that. Now, I always tell patients too, it's kind of the same thing as Afrin. Some patients know it, some patients go Aflac, and I'm like, no, it's Afrin. It's Afrin. And then it turns into a whole thing, so you guys choose your poison. But unlike Afrin, this low dose concentration does not cause any rebound effect, and they can pretty much use it indefinitely. Now, when they went through their clinical trials, basically what they were able to find is that they found this sustained and more of kind of a rapid effect within about 5 minutes. So you see within 5 minutes, and they did it at day 1, day 14, and day 42. And you see on average, there's about a 1 to 2 millimeter improvement. And that may not sound like a lot, but it's quite a difference. Okay, here's Upneeq, which lifts it. So here's a mild case. So look to the left of that mild, and then look to the right. I mean, it's kind of like they're going, pa. And you know, it's, if you've never used this, then I advocate get some samples, put it in your office, and offer it to some of your staff or whatever. But just do one eye. And what I always tell my patients when I send it home with them as a sample, I say, look, I'm going to write a prescription for you. They're going to call you. You do it through RBL. They're going to mail it to your house. I have nothing to do with it. There's, you know, if people say, well, you're not really generating revenue for the practice. And I'm like, yeah, I am, because they're coming back to see me. They're still my patients. I want them to basically be a resource for them to have something different and unique. And more importantly, too, especially in my practice, we do a lot of cataract and refractive surgery. The cataract patients tend to have a lot more acquired ptosis. And so now afterwards, I can help them to keep those lids open a little bit more as we follow them through. The younger patients who might want to get out of their contacts, those patients who are in scleral contacts, just there's lots of different opportunities within your practice. But if you tell a patient like this, just put it in one eye, wait about 30 minutes, and then go look in the mirror. I mean, just you see the dramatic difference between the two eyes. And that's just in a moderate eye. And here's that severe eye where I think the MDR was about like 1 or 2 max. And now look at them. I mean, this is after 2 hours in both eyes. It really does work. I mean, it also tends to kind of whiten the eyes as well. Okay. Something else.
Hey,
And
Mark,
lastly,
when we do surveys, we always drop
Mhm.
these acronyms and we get, need to know what the acronyms are, especially we do OCT, so on and so forth. You just said MDR, which stands for marginal reflex distance. Can you just maybe
Yeah.
show someone what that means? Because, we get the surveys, and if you can go back and maybe show what an MDR, there's an MDR1 and an MDR2. So you always want to show
It's
that.
the marginal reflex distance right there. So literally it's the center of the pupil to the upper lid. And if I said MDR, I'm just throwing out words.
Or
That's like
MRD,
Hackneyed.
so marginal reflex
MRD.
distance. So it's the light reflex there, and then up, it's a reflex up to the lid margin. So
Reflex.
there you go,
Don't do it.
MRD1, and then MRD2 is actually from the light reflex down to the lower lid.
There we go. But we don't care about the lower lid.
We don't.
We just don't care. Yeah.
I'm going to actually, as you're speaking here, go through my phone, and then at the end here, I'll show some really cool UpNeek outcomes that I've had. So
You got some?
Oh,
Nice.
yeah.
I should have put some in my own eyes, but I've never used it. I love watching patients come in and use it. The other thing too is it actually whitens the eyes too, as you think it would. Now there was an ophthalmologist that I was working with. Her name's Laura Perriman, and Laura would take a little bit of Lumify and put some UpNeek in there and make a combo. But she's crazy like that. So let's talk neurotrophic keratitis real quickly. And when I say real quickly, just because, I have like 100 more slides to go. But, NK, corneal intervention is the key to treatment, right? The superficial punctate keratopathy can lead to corneal ulceration. We can start to see these corneal neuralgias, right? Intense pain with no signs. Now, when we have somebody who's got neurotrophic keratitis, or basically they don't feel anything on the eye, there's some intervention to the cornea which has been hampered. And I'm going to give you guys some examples of patients. Now, the funny thing is that, a drug rep came into my office today, who I've known for a very long time, and he asked me, Mark, what do you think about Oxervate? And I said, or Dompe. And I said, what do you want to know about it? And he said, how common is it? And I'm going to say it's not very common at all. I go, but it's more common than most practicing optometrists realize. And the main reason why is because we're not testing corneal sensitivity. When a patient comes in with dry eye, or a patient comes in with an ulcer, or a patient comes in with infiltrates, how many of you are actually, maybe even taking a cotton wisp or taking like a fish wire, like a fishing line or something, and actually doing a corneal sensitivity test? Not many of you, but it's something that, and I know Greg is pretty passionate about this too, is something that we all should be doing. Now, traditionally, we would treat these with just putting drops on there and just getting frustrated. There was an ophthalmologist on the East Coast named Richard Adler who wrote a whole paper called Pain Without Stain, and literally how patients would come in just like wanting to rip their hair out because they were in so much discomfort because of the neuralgia, because of the changes to the nerve endings in their eye, versus the patients that come in with this open wound, gassing ulcer that's not healing, that have no idea it's there. So, we would treat with anti-inflammatories, we'd put them on autologous serum, maybe do some amniotic membranes, because we didn't have a treatment, but we do now. Now, one of the very first cases that I ever had that I used this was this patient right here. Okay, this was a 72-year-old male. He had cataracts in both eyes. So we scheduled him for cataract surgery in his left eye. He started using his pre-op drops, and he came in and he said, I might have hit my eye with the drops. Now, I'll be honest with you, I use the tease all the time. And when patients would read package insert, I would tell them to skip the part where it says, don't touch the tip of the bottle to your eye because it could cause an abrasion. And I'd be like, don't do. But if you need to, go ahead, because 99213 generates some rev for the practice. But he took it to heart. He thinks he hit his eye. So if you look at his left eye, he's now counting fingers. Okay, his right eye is clear, still got the cataract in there, but this is what he did. So to me, this wasn't really a significant abrasion. It looked quasi superficial. You can see kind of like the feathered edges there. So I basically put him in a bandage contact lens. We talked about putting it into a Procura, which I would have liked to have done, but I couldn't because from a monetary standpoint, it just wasn't going to work for him. He came back after a week and he said, I don't think the contact's there anymore, but my eye feels good. I'm good. He goes, you're the man. Let's get ready for surgery. Can I have my surgery on my other eye? And I'm like, there's no way. I mean, the abrasion was worse. It was starting to ulcerate. And more importantly, I went in, I took my little cotton tip, and he was basically 0 out of 10 on that left eye. So at this point, I basically inserted a Procura Slim, put that in there. I told him we have to do this now, and did nothing. And so this was my first patient that I prescribed Oxyzate for. Now, we have these endogenous, neural growth factors, and they basically have this high affinity and low affinity, right? Corneal intervention, they play a significant role stimulating the survival of these nerves, right? And more importantly, they allow cell proliferation and differentiation, and they also are effective in tear secretion. So the corneal nerves, basically, in these growth factors really support the integrity of the cornea. Well, the problem is that, when they're not there or they don't work or they're in low supply, then we have problems. And so literally what we're looking at here with Oxervate is essentially structurally identical to the human nerve growth factor. Okay, so it's a naturally occurring neurotrophin, which can differentiate, and they use this regenerative potential growth. And essentially it's a recombinant human nerve growth factor, which is structurally identical to that. So when we prescribe this, now the challenge here in prescribing this for these patients is the fact that, yeah, it's an orphan drop. It's not going to be, I'm going to send you to the pharmacist. This is something you're going to have to work with Dompay with. And, when I talked to that rep today, and I said to him, I go, I have prescribed maybe six times I prescribed this. And he goes, you know what, that's amazing, because we know that this isn't going to be a tremendous amount of use. But in optometry, I think we're missing a lot of these patients. There's a lot more patients that could basically be using Oxervate. It's supplied in a weekly carton. It has 7 multiple dose vials. So they have these vial adapters. They get these pipettes, because what they're supposed to do is do it 6 times a day for basically about 7 weeks. Okay, and so it's going to be shipped to them. It comes in this cool pack. They have to carry it around with them. And so, to me, for those patients, I had a herpes zoster patient who had an ulcer. She had no idea that she was ulcerating. I had another patient with a neuralgia who actually did phenomenally. She was just out of her mind in pain. She did so great on the Oxervate, and it lasted probably for about 6 weeks, 8 weeks after, and it started regenerating again. I wish there was a way I could keep her on it longer. During their clinical studies, they found after 8 weeks, 6 treatment, 72% were completely healed and 65% were healed. That was in the NK study. What you see is of the patients who healed after a 8-week course, 80% remained healed for at least a year. And I've seen the exact same kind of response in my practice as well, okay? Exact same type of response. So when we think about this Oxervate, it's every 2 hours, 6 times daily, basically. We're going to do it for about 8 weeks, instilling 1 drop in their eye. This is from Dompay. All right, look at your patients, look for those patients that aren't healing, and seeing what you can do in there, especially for those patients. The cost to the patient, and that's a really good question. Thanks for asking that question. Every patient that I had, it was covered under their copay. Now, part of it is because they got a grant from Dompay. So you definitely are going to want to work with the company. I had no patient that paid more than what their copay was. And that was just outstanding, and it was just great. So and they're a great company to work with. Really, really great company to work with. So check it out. Okay. All right, let's get into some FDA investigative drops or drugs, shall we say, okay? Because there's some really novel stuff coming down the line. And I probably will spend more time than I should on these because none of them are FDA approved yet, although one of them most likely will and is going to probably be out before the end of the year. In fact, they're already hiring sales forces in your neighborhood when we get to that. Now, the first one is basically a Demodex medication. And yeah, Demodex, okay? Yeah, we talked about it a while ago. Remember, big thing, right? Get your microscopes, find the little Demodex, and then we kind of just lost sight of it. But the one thing that we don't lose sight of is collarettes, is more collarettes, okay? That from Gaddy vision, I'm not gonna say that's Ben Gaddy's eyes because it's not, it's just from his practice. More collarettes, okay? Little ingrown hair, more collarettes. Now, there is a way of evaluating the cornea or evaluating the eye. Ooh, we have a polling question. Ooh, polling question. Which of the following is not an FDA approved drop? Okay, I'm gonna go with it. Are we doing this polling question? Because I'm doing it. Did it.
Need to keep it live and interactive.
Yeah, that scared me. That totally scared me.
Oh, sorry about that.
That's okay. But I do want to show you, this is my new poster for 2020, 2021. Hang in there, buddy. Hang in there. It's almost 2022.
So we had a comment come in on a private
Okay.
private comment to me
Oh.
here. Mark, it says, I thought we had to see a patient within 1 to 2 days after inserting a regular bandage contact lens.
Oh,
A
no, my
week
friends.
question mark.
So, private question. First and foremost, bandage contact lenses are not FDA approved for abrasions. You're going off label, my friends. You are going hang time rogue. Now, for me, if I don't perceive that there's any inflammation, infection, anything going on there, because I did put them on an antibiotic, to me, the longer you can keep that lens on the eye, the greater healing they're going to get. That to me is also another kind of Hackneyed kind of mindset, is that you see them back the next day. If there was a vegetative response, if there was concern about getting, some microbial type of infection, yeah, then I probably would definitely see them within 24 to 48 hours. But for the vast majority of these patients, especially with abrasions, I think a newer way of looking at it is trying to keep the lens on there longer, especially with the recurrent erosions in that manner. And that's what I really thought we were dealing with here, was strictly just an erosion. So that's why I kept it on there longer. But good comment. Yeah. And if anybody wants to make this a screenshot, let me know, because I think that'd be a great poster. Get rid of the cat. It's all about the Demodex. Okay, hang in there, buddy. Okay, yeah. So we're talking Demodex. Now, you can't talk Demodex without also talking about rosacea. And there was a meta-analysis of 48 studies, 10 different countries. Rosacea patients 7 to 8 times greater chance of having Demodex. Think of all those pictures I just showed you. Just go back and look at one of them. Okay, right? Do you not see the rosacea going on here along these lid margins, the matarosis, the thickening, the neovascularization? The meibomian glands are probably cray-cray as well. So we see this strong correlation between Demodex and rosacea, as noted right here in this study. Okay, so there is a company, and this company basically is called Tarsus. Tarsus is out of Irvine. And what they did is basically started looking at the percentage of overall population with collarettes. And they found in a study that was done in Arvo by Teo and Jacobson, they basically found that about 58% of their patients that had a dry eye diagnosis, 58% also had collarettes. When you start looking at the percentage of collarettes within each group, patients that have blepharitis, 70%, dry eye patients, 60%. Cataract patients, contact lens patients. The collarette is pathognomonic for Demodex, okay? And so they did another study, and I'm sorry that I didn't fix my title page up there, but this was called the Atlas study. And what they were doing is they were looking at that symptomatic and psychosocial burden of Demodex, and they found that 80% report negative impacts. Okay, when you start looking at on the left-hand side there, the multi-center observational study of these patients, they found that, eyes that itch and dry eyes, 52% experience the top 3 symptoms frequently or all the time. When you start looking at functional and psychosocial impact, males versus females, feeling conscious of their eyes all day or difficulty driving at nighttime, these are patients who have an impact from Demodex blepharitis. Now, when we talk about these collarettes, and I mentioned to you that these are pathognomonic for Demodex, this was a percentage of subjects with Demodex. Okay, if there's a collarette, 100% of the time they would have Demodex. They would have a Demodex mite attached to there. With no collarettes, using lid scrubs, they maybe see 50%. No collarettes, no lid scrubs, 7% of the time they saw the Demodex. So these Demodex mites are basically found in about 58% of patients. And I was part of this study that we did where we basically just walked in, looked at the patient, pulled up, looked at the lid. And this is what's really important. And this was Elizabeth Yu out of Virginia. What Elizabeth did is basically like, you're going to miss these mites. You can miss them quite easily. Okay. You see on the left-hand side here, this lid, right? If you don't lift up the lid, see how now on the right-hand side, you can actually see the base of those lashes. So Ascaris or ASCRS came up with this moniker, which is called LLPP. Now it's basically meant to be, and Greg, I know we talk about these things, it's look. So you're gonna look at the eye, make sure everything's fine, but the LP is lift and pull. That upper lid is to get underneath there and see what's going on there. Look for Demodex, look for misdirected lashes, look for SPK, look for SLK, look for other things that are going on under the lid. The last P is for push. Push it real good, and we'll talk about that in a second. Collarettes can be seen on the lower, when the patient looks down, you can see it much easier too, as well as those, like I said, misdirected lashes. Now, if we're correlating a Demodex mite 100% to a collarette, then that basically means that every one of these has it. Now, lotilaner is the molecule, and this is basically a non-competitive antagonist, and it comes from the veterinarians. The vets are legit, my friends, because literally there's another drop that we could talk about that came from veterinary medicine also. But for all intents and purposes, this is like what kills rabies and kills other things that your dog's probably already using. And so getting it in, and it's funny, is that mechanism of delivery, the MOD, as to literally what Greg said earlier, is what makes this novel, because they were able to take this same molecule that some of you who have cats and dogs have maybe kind of noticed, oh yeah, I use that on my cat or my dog, but now we can actually put it into the eye. So it's going to be a multi-dose eye drop solution. It's going to treat the Demodex. We're talking eradicate the Demodex. Okay, it paralyzes them and it kills, CILL, the Demodex. Okay, the collarettes basically start to kind of, dissipate, you clean them off, you get rid of them. So their primary goal here, the primary efficacy was for collarette cure. Secondary is to completely eradicate all the mites. And then another secondary goal is for the redness around the collarettes. So in their clinical trials that they've been doing, and they're doing quite a lot of clinical trials, they've got some really great results. So this is a medication, TP03, which you can see here on the left-hand side are the Europa, Jupiter, Mars. They've completed all these studies. They're now going into their phase 2B, phase 3 Saturn study, and then they're going to start the phase 3 Saturn 2 study. Okay. And so these are going to be initiated basically in May of 2021. So they've already started these studies. So this is a medication that I think we're going to see relatively quickly. When you go back and look at their study, 90% reduction in collarettes, okay? Clinically meaningful collarette cures. So if you look at the right-hand side there, the average baseline grade 3, right? And then grade 1, and then down to grade 0. So literally what you're looking at by day 43, about 81% of the patients that were in this study had 0 to a grade 1. And that's, basically over 100 to less than 10 per lid. And that's what you're looking at from these collarettes. When you look at a collarette cure of 0 to 2 collarettes, the average baseline grade was 3. To get down to 0, about half, 43% of the patients, got 0, which is really, impressive to show how it just kind of kills. It kills the Demodex, and it really just puts them in a greater chance here. You see 68% of patients experience complete eradication at 6 weeks in this secondary mite eradication, which is nice as well. So the collarettes are gone, and 70% of the patients, the bugs themselves are gone. And then lastly, we can think about this erythema score. And I think what's important when you're talking about Demodex treatment is we talked about how the eyes look, not only how they feel, but getting rid of the mites, which we know is going to take away the itch and the discomfort that we saw with these patients, but it's also going to make the eyes look healthier. And we see here too, about 68% experience a grade 0 to 1 collarette and erythema score. And so that composite score, you see here that endpoint of cure observed by week 2, we get a clinically significant change, and then we basically get about 15 or 13.5% with that secondary endpoint. So good stuff, See here, 19% experience a complete erythema cure, and 45% experienced erythema improvement by day 43. What are the adverse reactions to this veterinarian-induced medication? Very little, just a little bit of some sight discomfort. But let's be honest. If you told a patient they have Demodex on their eyes, they're going to be uncomfortable. They're going to be uncomfortable. It's going to make them feel like uncomfortable. Shh, let's just not talk about that. So I always like just looking at the pictures, at the improvements here. When you look at complete collarette cure on the left-hand side, right? Post-treatment, day 43, when you look at that clinically meaningful collarette cure, and you can see the differences in the two eyes, and then that erythema response, where you look at the conjunctiva, you can see how much better they look. So this drop has a good place. Probably looking at 2022, 2023, okay? So if anybody gets this one wrong, that's sad, okay? That means you have it muted and you're watching something else. You're like on episode 9 of the Squid Game, and you just got to get it done. Got to get it done. But yeah.
Mark, don't
So,
worry.
Mark-
I've never gotten 100% of one answer, even when there's only one answer.
So Mark, as you're talking about, TP03 here, it's exciting to have something coming down more than maybe tea tree oil to treat this. But we always call it collarettes. And what I found really interesting to say to the patient, yes, these are collarettes. We take a picture of it, but it's really just Demodex poop. This is what's building up. This is what's causing the irritation. Your body's having that, we talk about the innate and adaptive. It's having that adaptive response. So, it's just, call it what it is. And then I think we get a little bit of better reaction to get the patient to treat it. So
you're going for that shock factor, huh?
there you go.
Yeah, these little bugs are just vomiting and crapping all over your eyes. I'm just saying. You have a good night. Seriously, I want to find out who said podiatry. You raise your hand right now. All right. So another opportunity for us is, to me, I feel one of the most common complications that we see in our practices right now, and that's meibomian gland dysfunction. When you think about MGD, spacious glands, no direct contact to hair follicles, these are basically, the meibomian glands are, for all intensive purposes, hairless follicles. Think of them that way. Think of them as a hairless follicle. They follow the tarsus, more in the upper lid, higher volume in the upper lid as well. And the relative function is to contribute to the tear film. It creates that layer of lipid, which in turn basically stops the eye from evaporating their tears so quickly. Think of it as like the roof on your house. Think of it as the saran wrap on your cookies you just made. And some monster takes it off and now they're all hard. Yeah, same as your tears, my friends. I always tell patients when I'm doing that push aspect, I'll say, look, these glands get obstructed and they get inflamed. So we got to talk about the obstruction and what we can do about that. Melting, heating, changing it up a little bit, excuse me. But then we also talk about the inflammation. And so that's where some other medications and things come into. MGD is, and I believe with Carolyn Blackie, And Don Korb, the leading cause of dry eye. It is. I mean, I challenge you, I dare you. Even the person who said podiatry or none of the above, I dare you to go into your practice tomorrow and find a patient whose meibomian glands look healthy, looks like olive oil. You know, in their studies they did, they found that 86% of qualified dry eye patients demonstrate signs of MGD. But here's the caveat to that, is that there's new research and new belief, it's never been new, but it's old, but it's still belief, is that hyperkeratinization is indirectly or directly leads to the alterations of those meibomian glands, causes decreased meibum, causes atrophy, cystic dilation, as well as ductal plugging. Now, keratin basically builds up, right? If in a hair follicle, okay, your nails, your hair, you know, dandruff, this is all different forms of keratin. And the more disulfide bonds they have, then the greater opportunity those keratin can get stronger. So with a quick opportunity here to answer this question, if we're thinking about breaking disulfide bonds, which shampoo would be good to help with things like dandruff, extra keratin buildup? Yeah, interesting. I know what I'm going to check. Da, da, da.
And for the, I'll put the handout in there again. I did put the handout in the chat box at 7:15, but I'll put that in there again. Again, it will be in the link 6:45 and then post event. But for those who like it here, I'll put it into the chat box again. All right.
So
So
I'm going to keep going. Well, you got that
yep, I'm
quiz
gonna
going
share the
because it's going to be
results.
it's good job, good job. Now I just think people are just messing. Yeah, totally. But hyperkeratinization is the primary cause of this obstruction. If we believe that, okay, certain studies bear that out, then heating the meibomian glands is not going to change anything. We actually need to target this aberrant keratin buildup, which is causing the plugging of the meibomian glands. This is from Azura Pharmaceuticals. They're out of Australia, mate. It's not, that was a horrible Australian accent. Yeah, top of it now. Hey, yeah, I can't do it. But this is AZR-MD001. And literally what this is that if you look at these keratins, which are these structural proteins, as I already described before, they are extremely resilient to heat. They're not soluble, okay? These disulfide bonds, or these sulfide bonds, basically cross-link. And when they cross-link, it makes them harder. So literally, if you try to melt them, you would have to get it hotter than 144 degrees Celsius. Not going to happen. But we could chemically denature them. And that is the goal here, by chemically using like a mild disulfide, something like some blue, to disrupt that agent. Because what you're doing is you're looking at selenium sulfide as this mechanism of an action to basically create a keratostatic, which slows down the rate of the keratin. It's a keratolytic. It softens the keratin plug. It breaks down those disulfide bonds. And it's also a lipogenesis, which stimulates the production. In their early studies, they basically look for things that are called thiols. And thiols are basically just free sulfide with hydrogens attached. So if you have a sulfide, disulfide bonds, and you break them, they're going to attach to a hydrogen. The more of these that you have lying around, it indicates that you've broken these bonds. And so you can see here in their 2-hour incubation and then their overnight incubation, you see a clinically significant amount of these free thiol moieties, which are basically against the control. So this has got a little ways to go, but I do think it's something exciting because it really just kind of changes us, brings us into something different. So the last FDA new drop coming out there is from Oyster Point. Now, Oyster Point is a relatively new company, but it's kind of got its origins from something a little bit older. And I don't know how many of you guys used something called the True-Tear, where you kind of put that thing all up in your nose and stuff, okay? But essentially, the person, Michael Ackerman, who is the guy who invented the True-Tear, which Allergan bought from him, Oculive, I believe, is the company, he then started a couple of other companies. And this is his one company, and this is the product that is most likely to be coming out before the end of the year, the beginning of next year. If we think about, the notion of true tears, real tears, all of our tears come with 1,500 different proteins, 5 different lipid classes. They have growth factors. When you tell a patient to put in an artificial tear, it's artificial. Okay, it's just, that's exactly what it is. But if we could somehow stimulate a natural tear, okay, a basal tear, okay, and 34% of these basal tears are produced from just inhaling. Okay, this is associated with the trigeminal nerve, right? We got our trigeminal nerve. It's accessible within the nasal cavity and is stimulated by cholinergic receptors. So the trigeminal nerve basically provides the pathway for this parasympathetic stimulation of the lacrimal functioning unit to make a true tear, a natural tear. And this is essentially what we're looking at when we look at this lacrimal gland post-ganglionic intervention. Okay, so the LFU, or the lacrimal functioning unit, innervated by the trigeminal nerve, which affects the meibomian gland, the lacrimal gland, as well as the goblet cells. And all of these basically are stimulated by a parasympathetic nervous system. This is varenicline. I think I said it right. Al Cabot will kick my ass if I said it wrong. But this is OC01. And again, I believe this is from veterinary medicine. I'm just saying, okay? And this is a nasal spray. So the route of administration is through the nose. It's preservative-free. It's 50 microliter spray delivered twice daily to each nostril. They have a 0.6 milligram concentration. That's 30 sprays. And then they have a 1.2, which is basically 60 sprays. And they basically feel that it lasts for at least 2 hours inside there, creating these tears. These are their different studies, and I'm going to go through these relatively quickly because the bottom line here is that it works. The nasal spray works. So the varenicline basically evaluated over 1,000 patients with dry eye disease. They looked at, primary endpoints of objective dry eye disease signs. They looked at secondary endpoints of symptoms. And then they did these multi-centered randomized double masked studies to see where they were at. Okay, when they did their studies, they did them good. They did them right. They did not utilize a placebo run-in. Okay. There is no contraindications to this point. They included all-comer eye dryness scores. So unlike other studies that you may or may not realize, but other dry eye medications that were approved, they picked and chose. If they were super severe symptoms, then they took the people that had little signs, or vice versa. The crazy signs, they took the ones that had very little symptoms. So what they did is they just enrolled these basically from 0 to 100, Schirmer scores less than 10 millimeters. And they allowed the subjects to keep using an artificial tear as they wanted to. And I think that's great because, you want to basically do real life. So this is the onset 1, onset 2, randomized 28 days. Here's their data. Mean change in Schirmer scores was the primary endpoint, and the posterior was the categorical Schirmer scores. And here's an integrated data of both. So when we look here, we saw that it improved signs as early as week 4. Patients, had greater than 10 millimeter change from baseline in their Schirmer scores in all the data going across here, as you see the 2 different studies. Okay, when we start looking at improved signs at week 4 with their integrated data, we see again, all 3 of them, did really well. And you can look on the right-hand side there, 297, 275 patients. They were in onset 1 and onset 2. And we basically see the mean change in their Schirmer scores greater than 10 for the vast majority of these patients. When we look at improved symptoms at week 4, we see again, significant change in increased symptoms from baseline. Now they came out with their MYSTIC data, and this was their basically phase 2 study design as well as phase 3. This was a longer study. This was like 3 months. So here we were talking 1 month. Now in the MYSTIC study, they've taken it out to almost essentially 3 months. Okay, and again, I'm going to share with you, they met all their primary data. If you look at the MYSTIC data, you can see there, going out to day 28, same essentially profile across there. When you look at the integrated safety data, for those of you who asked about contraindications, there was a little bit of cough associated with it. But the biggest thing I would tell you is that most subjects reported a sneeze, a little bit of a sneeze, but 98% of it reported it as mild. And almost nobody dropped out of the study because of it. And I always think that's the most important thing. You look at the side effects, but you say, but did the person drop out of it? No. Okay. 82% of the group reported a sneeze in the 0.6 and 84% in the 1.2. 22.4% of subjects in the placebo group were sneezing as well. So I don't look at that as a barrier at all. This will be approved. And this will be an opportunity to basically offer your patients a way to make real tears, to just make real tears. So those are our drops. And you know, with about the half an hour we have left, I'm going to choke to death here. I'm too verbose, and I apologize. We're going to get through some other exciting stuff. Something else that's relatively new, which I hope is somewhat nouveau to you, is the way we can look at patients who have corneal dystrophies or who have keratoconus. You know, back in the day, how did we prescribe or diagnose keratoconus? We got a really bad refraction, must be keratoconus. We started getting topographies. We're like, oh, let's get a topography. If you have a topography, then you see the curvature on the cornea. But then also we started talking about the fact that we can now do something to maybe manage this. We have patients that want to have refractive surgery. Do they have a problem with their cornea that may limit them from having good quality of vision 10, 15, 20 years down the line? The question is maybe. So looking at genetics is a way or an opportunity for us to be able to do that. Genetic data helps us perform the right refractive procedure on the right patient. But more importantly, with their little motto, which I love, is genes are talking. We'll help you listen. Avellino Labs. Come on, give it up for that marketing right there. Solid marketing there. Okay, this essentially is 75 genes, 1,000 different variants related to keratoconus, and 70 different TGFBI mutations. It's one swab. It comes in this little box right here. We'll go through it real quickly. It personalizes the refractive procedure decision for doctors like myself. You know, if you go back and you say, look at that topography, I don't know. I mean, if you look at the topography, you see how it's kind of bending more towards inferior. You know, we used to back in the day look at that and say to ourselves, that looks just like an irregular against the rule of astigmatism. In our practice, we actually named it after the first person we ever saw with in 1995. And we thought nothing of it. Well, now we know that that's basically pellucid marginal degeneration. And looking at something like that where it's maybe not as obvious, then you might not have all the information you need. That would be a perfect person to say, you know what, I'm just not feeling it. It's a funny looking topography. Let's get you in. Let's do it. We could do a genetic test in the practice, get the results, and it's going to come back. It's going to quantify the risk for these patients. It's going to tell us specifically whether or not they have any of these markers or genes for something like corneal dystrophy or lattice intermediate type dystrophy. You know, it's essentially an easy testing method. Okay, you buy the kit. The kit, I think, let's use a number, and I think it's around, let's say, $200. So you buy the kit for $200. To get the testing done, it costs $100. So there's a $300 cost to do this. So let's say you charge your patients $350. I'm just throwing out random numbers. You know, part of this lecture is not to sit here and say these are the numbers you should use, but you know, you do you, boo. You do you. Okay. So literally, you have the test in there. You, technician, basically, you know, does the swabbing. You stick it in the package. You send it overnight. Within about 2 weeks, you get a digital report. Then you also get the opportunity to have some discussion with a counselor. Okay, so when you get the report back, it could say something like medium risk for post-LASIK ectasia. You know, no other things were detected, but there's a concern there, okay? When you start looking at somebody who has maybe Leber's congenital amaurosis, we start talking about some of these rare genetic or autosomal recessive type of corneal dystrophies, it's nice to know if your patients are at risk of that before you do surgery. It's something like lattice corneal dystrophy. We start looking at this generation sequencing. They're constantly updating it. They're getting more genetic tests for us. So what's nice about this is that you're going to know early, you can act personally, you can decide confidently. And it's a good tagline. So if you're somebody who works in a practice where you do a lot of contact lens fitting, or if you're seeing peds or kids, then I would tell you to contact Avellino and just see about getting an Avogen kit in your practice. It's a low cost to you to start it, and see how it might be able to help you to find these patients earlier. Because something else that is picking up a lot more steam is basically cross-linking in the USA. Okay, and we put this on here a little prematurely, but I'm going to tell you that it's cross-link. So there you go. Okay. It's approved, only one procedure is approved in the United States by the FDA. And it's about cross-linking for the eye. Just going to say that out there. But corneal collagen cross-linking, for all intents and purposes, is not new. Theo Seidler, basically in 1998, went to his dentist and he says, "Was is this? You're using some extremely," he was from Dresden, Germany, by the way. "You're using some enamel that you are highlighting with the UV lights. This is great." He went back to his laboratory and he started irradiating these rabbits. And literally what he found in these studies was that he could stiffen these rabbit corneas like 98 to 99% successful if you just look there. Good job, everybody. The I don't care person, I'm right there with you. I'm right there with you. It's almost over. The pain is almost over. But using this UV light, exciting these riboflavin or using some certain sugars to create superoxides. The funny thing is we're all talking about getting rid of superoxides. Now we're talking about let's make some superoxides, and that's what we're dealing with here. So cross-linking creates these oxides. In corneal collagen cross-linking, when we look at the distribution over time, the goal of conventional cross-linking for the treatment of keratoconus is literally meant to basically stabilize and basically create a mean flattening of the steepest cornea in the largest percent of patients. And we see that progressive change with our keratoconic patients. So this is the Glaukos iLink system, the only FDA-approved epithelium-off corneal collagen cross-linking. When we think about keratoconus, here in the United States, we think it's about 1 in 200, but in other countries, like for example, the Netherlands, it's as high as 1 in 375. I think the prevalence is much higher. 1 out of 5 people with keratoconus need a corneal transplant. Think about the burden that's going to put on us as a society, but think about all your patients, right? I mean, any patient that has keratoconus, it starts early, right? It could be the eye rubbing, or is it the keratoconus? Is it the weakening, the proteins that are within the cornea? Is it genetic? It's across the board. It's all over the place. But how we got there almost kind of doesn't matter. But what can we do about it now? The FDA-approved iLink system, I believe, and don't quote me, but I'm almost 100% sure, is they did their clinical trials in patients as young as 14 years old. Can you go younger than 14? Yes. If you have the approved system, we'll talk about that in a second. But it's kind of like bandage contact lens, dropping in the eye and leaving it for as long as you want. It's off-label. You're going off-label with a FDA-approved device. So this uses the Photrexa viscous, and this is a riboflavin, or that sugar solution, a riboflavin phosphate and the dextrin ophthalmic solution, and then Photrexa, which is their phosphate solution, which is meant to help thicken the cornea. The name of the laser is the KXL, so it's this whole delivery system, because you could go and get the Photrexa or the riboflavin made at an apothecary, but it's not going to be FDA approved. And there's no way of saying whether or not it's going to have the same concentration. These have been tested and utilized for years to get through here. So the indication is for progressive keratoconus and corneal ectasia following LASIK surgery. You remove the epithelium just like in the Dresden technique, like Theo Seidler did, to expose the cornea for more oxygen. 30 minutes of riboflavin application, 30 minutes of exposure. The cornea should be about 400 microns thick so that the UV light that penetrates there basically stays within the cornea. Do you remember I talked to you about the Photrexa solution? That acts to basically create a thickening of the cornea. And so we see that for patients that need it. In their laboratory study, they basically suggested that it creates about a 328.9% increase in biomechanical rigidity. Yes, literally what you're doing is you're having your patients go outside, look at the sun, get some UV light, harden their cornea, which is what we do every day. We cross-link every day, my friends, okay? We cross-link with leather. We cross-link with jello pudding, with the jello pudding. Too soon for that impression? I don't care. We cross-link when we do like our hydro flasks. There's all types of different cross-linking going on. So this iLink procedure is the only FDA approved, so anybody else out there, right? And the most common adverse reaction was a little bit of a corneal opacity or a haze. And also we could see a little bit of ulcerative keratitis because of the healing of there, but I've never seen that. Never seen it. So remove the epithelium, soak the cornea, as I just mentioned, check for flare. You can actually see it because it has a fluorescent tracer on there. You look inside the anterior chamber, you can see the flare. If the cornea is not 400 microns, you add the Photrexa solution, bring it up there, and then you fire up the UV light. It's a very basic procedure. So when we think about FDA approval, careful precisions, studies done, we can use it off-label. Some off-label uses would be maybe to control myopia, to treat an ulcer, right? A bacterial conjunctivitis or an ulcer, or I should say a keratitis that's not healing, right? To go in there, eradicate the bugs, kill the bugs, CIAL. Not FDA approved means that it hasn't been determined, it hasn't gone through this. And there's a lot of black box lasers out there. There's a lot of doctors out there that are utilizing it off-label. In Canada, they're using cross-linking to create refractive surgery. I mean, imagine if you could redistribute the corneal stress. So for somebody who's like a myope or a hyperope, you could do something called Pixel, which is photorefractive intrastromal cross-linking. What they do is they basically inject some riboflavin, apply it to the cornea. They use this mosaic device to figure out exactly where they want to have the cross-linking work, and they create this customized treatment. So the pattern of the UV light for a myope would basically be more central. For a hyperope, it would be more peripheral to kind of take some of the stress away from there. This is not going to be a tremendous amount of correction. We're talking a few diopters, but you know, seeing some data here. Here's a 38-year-old. Look at their pre-op minus 175, and this is the way I evaluate my cross-linking patients. And I know this is a refractive procedure, but you know the B was the pre-op, the A is the post-op, and then you look at the difference map, and you basically see here you're going to see that it's basically flatter in the center, steeper on the edges, which is what we want for a myope. What I like to see for my keratoconic patients is pre-op, post-op, and it's just all one color. The difference map has not changed, and that's a beautiful thing. So with the few remaining amount of time we have, we're going to delve into just a few more topics, but we cannot stop without talking about presbyopia.
Hey, Mark, let me just
Go.
echo real quick here before you move into this, because when I talk about cross-linking, one of the things I like pointing out is that, you know, all day long, we're trying to stop oxidation. We're trying to stop aging. We're trying to stop the free radicals, macular degeneration, trabecular meshwork, the crystalline lens forming a cataract, using, you know, AREDS formulas and, you know, and all these different antioxidants. But what we've done with cross-linking is just the opposite, right? You're soaking it with that Photrexa, that riboflavin, which I think is like B6 or something. And then you're hitting it for a half hour with an ultraviolet light and creating instantaneous aging and stiffening to that cornea. So, you know, it's kind of neat, kind of taking something that we're trying to stop every day, aging, and kind of in a half hour's time, you know, create that and stiffen that cornea. So
It is.
Just wanted
It's
to
pretty
echo it.
cool.
You said it, but I just love the science behind it. So
Well, now, so now what's funny though, Greg, is now we're going to talk about reversing the aging process as we talk about how can we stop presbyopia. And if I can, I'm going to digress for 2 seconds and tell you that, when I first started practicing, I was fortunate enough to be involved in quite a lot of clinical trials, and I still am. And I used to tease patients that if I could figure out a way to stop presbyopia, I'd be a billionaire. And so I used to talk about maybe creating like a suppository. And as your presbyopia got worse, the suppository would get bigger because if you think about it, you're just going to keep squinting. Well, little did I know that in a small sense, that's almost kind of what we're talking about. A little bit different. We're not talking about squinting as much as we're talking about controlling pupil size. There is no escaping presbyopia, my friends. 2 billion people worldwide. It starts in the 4th and 5th decade, as we all know. The different theories of causation, whether it be ciliary contraction is weakened or that the lens builds disulfide bonds, causing keratinization, hardening of the lens, as we've talked about before. The treatment that we've always done is basically glasses, contacts, or refractive surgery, or basically just told them to suck it up. Refractive cataract lenses, we've got the Tecnis lenses, which have done a phenomenal job holding steady with these, their multifocal kind of ring design there. The Tecnis Symphony used this concept of extended depth of focus. And that's going to be an important concept because extended depth of focus basically means that we're not creating multifocal effects, we're creating just an extension. And what's nice about the Symphony lens still is that it's a great distance lens and it gives a range of vision. It doesn't necessarily give a great close vision, but for patients who, pilots, etc., this is a really great opportunity for them. It merges 2 complementary enabling technologies, these echelet designs where they change those rings to higher or thicker, lower or narrower, and it gets rid of the achromatic changes which a lot of these lenses have. Johnson & Johnson also brought out something called the iHance, and this was to meet the need for patients who have like mac degen or have post-refractive surgery. This doesn't have so much the echelet design, but it has a little bit of a bump to kind of give them more distance and just a tiny little bit of close. Alcon in this last year and a half has really taken over, I think, the market. They had the Restore with their different apodized multi-zones in the Restore 2.5 and the 3.0. We basically saw, less rings. It wasn't nearly as close vision as patients wanted, which was good. But then they brought to market last year the PanOptix, and the trifocal has really just become quite a easy lens for a lot of surgeons to drop in your patient's eyes because it works. It works really well. There is definitely some glare. There is definitely, going to be some contrast issues, but most patients don't really notice the contrast issues. But this is a toric version, as you can see by the little markings by the haptics there. And this trifocal lens literally does close, intermediate, and distance. Okay. Alcon also came out with the Vivity, and this is a kind of their version of an extended depth of vision. If you see the bump in the center there, that kind of creates because there's almost 2 little bumps there, it kind of creates a range that extends out a little bit. But this is mainly a distance eye with some close vision. In our practice, we utilize this a lot on patients that, like I said, have maybe some drusen or have some macular pucker, or they have a potential of having some retinal issues. We are going to see a pure 100% Pinhole IOL. This is the IC8 small aperture IOL. This is not yet to market. What I will share with you is that in February, they got their pre-market approval, which usually means about 8 to 10 months. So we're talking maybe the end of this year, beginning of next year. And this is essentially, if you know what the camera corneal inlay looks like, this is the camera corneal inlay inside an IOL. You might say to yourself, you might ask yourself, why would my patient want to do this? Well, there's not a lot of glare at nighttime, my friends. There's not a lot of ring or halos. And more importantly, this potential thought about using small aperture to extend the depth of focus is kind of what we do when we do pinholing in our lanes. Hence, let's open up the new drops. The ophthalmic drop future is going to be large. There are a ton of companies. Why? Because the patient's needs and the patient's drop development of this landscape has been evaluated. This is consumers rank the loss of near vision the #1 impact on their quality of life in comparison to other age-related ailments. In another study, they found the drawbacks of current presbyopic solutions. They feel glasses negatively impact their self-confidence, or contacts are inconvenient, multifocals with the glare and the halos, refractive lens exchanges, corneal inlays, which I just described, and hyperopic treatments less predictable. These are the list of all of the different pharmaceutical companies that are coming out for miotic drops, or basically lens softening drops. As Greg just mentioned, the fact that we're aging the cornea, here we want to go and reverse that process. And so there's these prodrugs. Novartis is leading the lead right there, UNR844. This is a lipoic acid ester, and it's meant to soften the cornea. Orasis is already out there. I believe that they're already doing a kind of like a formulary one, but the one that's FDA approved right now, if you look in the, where is it at? Allergan, AGN 190584. I can share with you, I don't think that I'm going to get in trouble, but I believe they came out with it yesterday. You know what? I'm not going to tell you. I want you guys to look for it. This will be approved before the end of the year. They are going to start marketing next year. I don't know if the name of it's come out yet. They had originally were calling it Presbyosol, but it's not Presbyosol. It's something else. But this is, you can see here, these are miotics. When you look at something like Visus, they're using Brimacol, which is carbachol and brimonidine together. And remember, brimonidine is that alpha adrenergic agonist. Again, what does that do? It kind of stabilizes the pupil so it doesn't get completely small and tiny, but it also breaks down those it constricts blood vessels so the molecule stays in there longer. What Allergan, which is the closest to getting approved, as you can see here, Allergan has already got their NDA, right? 1.25% pilocarpine with a little special sauce, my friends. It's something they're going to be calling FAST, P-H-A-S-T, and that's going to be like their vehicle, much like what Greg said earlier in this talk. This is their mechanism of delivery, and their delivery basically is to keep that pilocarpine, keep it pH neutral, so that it isn't, going to burn and cause headaches like some of our old school people will remember. But the other thing too is that it doesn't create a wicked tiny miotic pupil. So I'm excited about this because I think that, the miotic drops basically increase the depth of field by inducing that pinhole effect. And I think part of what's exciting is that if you modulate or keep the pupil essentially about 50% of what the pupil diameter was. So if you can reduce the pupil by about 50%, then you're going to increase the depth of field. You're going to keep their distance vision, but you're going to improve or increase their near vision. Okay. Now, the lens softening agents, to me, I think if you added in that pseudo accommodation or even accommodation on top of that, then the sky's the limit here. I mean, Burke Healthcare Research, they did this survey amongst 1,000 people and the attitudes about presbyopia. The mean age was 55. 49% usually have discretionary income for personal needs. 13% had previous surgery. And literally, in this study, they basically found that patients talking about presbyopia, they use things like freedom from glasses that are often scratched or bent, or, it'd be nice not to have to carry glasses, be able to feel young again. Now, what I didn't show you in that study is how much these guys would pay, how long they would do it for. And I took that out deliberately because the truth of the matter is that I think every single person on this webinar right now realizes that patients hate wearing reading glasses. And so if you can offer them something, and I think the biggest, concern, and I hear it with you too, is going to be A, how much is it going to cost for patients? And B, are they going to be willing to pay it? But imagine this, if you have a sample, this is what's great about this is if you wrote a prescription for a patient, right, for the drop that Allergan's coming out with before the end of the year, and you basically tell your patients, look, try it. You love it, fill it. You don't. then imagine, the opportunities for your patients. Again, this is going to be a prescription medication. They anticipate it's going to last about 6 to 8 hours. The biggest side effect probably would be just a little burn on installation. Some of the patients did get a little bit of headache, but comparing it to the vehicle, the headache was almost exactly the same. And 1% of the patients dropped out of the study, none of them because of headaches. So I think this is going to be exciting. I think it's going to be great. Now, if we can just take the last 5 minutes here, talk about a couple other procedures. This is Reflex. This is a refractive lenticular extraction, small incision extraction. I mean, basically what you're doing is you're using a femtosecond laser to create a lenticle. You make a very tiny incision and you pull the lenticle out. No real laser is being used. We're not using we're only using the femtosecond laser. We don't have to worry about a flap. We don't worry about exposing the epithelial tissue. It's exciting. No stromal hydration. It's like for laser cats, integrity of the cornea. We don't lose, the nerve damage. Good stuff. Good stuff. Phakic IOL is what you can look for. This was the old Nuvita lens. Yeah, patients they don't really like them in the anterior chamber. They came out the Verisize, which was great. But still, people don't want them in the anterior chamber. They want it in the posterior chamber. This is the Vision, and this is the Vision Evo. The Evo is not FDA approved yet, but you see the tiny hole in the center there? What that's going to do is allow us not to have to use a iridotomy. And, as much as we want to, have that transfer of the aqueous from the anterior to the posterior, you need an iridotomy. But sometimes if you make the iridotomies too large or too small, then you have some secondary complications. So the ICL, I have been involved with this lens since 1998. We perform more of these probably in the state of Arizona than anybody, because for somebody who's got a high correction, a thin cornea, or has a tremendous amount of astigmatism, then you know what? Why would you not go to the source? Go right into the eye. And this is a great opportunity. And so when the Evo comes out, I think it's going to make it even better. Now, posterior segment, I'm all about, using AR, using an augmented reality, or a virtual reality visual field, one that's cloud-based, totally portable. In fact, literally, I have one that came in today, and we use something, the Visual, and I'm using this as an example, but it's an enhanced version for eye care professionals. You see the device, it's like the Oculus, I think that's called the Oculus from Facebook, that puts it on your eye. It's downloaded to my computer. I can watch it being done while they're in another room. My patients sitting in there chilling. During COVID, I had patients sitting in there. Well, we're still doing COVID. During our lockdown or quarantine, I had patients sitting in their car, and I was doing this as long as I was attached to my Wi-Fi, which I was able to do, then it worked, and it worked phenomenally. It takes literally less than 10 minutes to do both eyes. Do both eyes simultaneously. 24-2, 10-2, Land.Cs, they're working on color vision, D15 tests. This is what your printout looks like. It looks like just like a normal Humphrey visual field. It's awesome. Adaptive DX Magilogics is also kind of doing something with this innovative headset. I find it really interesting. They have their personal assistant, which basically kind of you put it on there. You don't have to have the big device. That's from Adaptive Maculogics. There's a photonic scanner, and I think, Greg, you could probably talk about this way more than I ever could, measuring skin carotenoid levels. It's basically an antioxidant scanner, and so you can use it to find or to evaluate patients who have the potential for macular degeneration. High levels of these carotenoids indicate rich antioxidant defense. Low levels basically means that they don't. Those are the ones who should be in those BBCGs, or talk to them about vitamins, or talk to them about other pre-op or preemptive, proactive ways of looking at macular degeneration. I know I ran through that towards the end here, but hopefully over this last hour 40 or longer, you've kind of thought to yourself, I got to get out of some of these Hackneyed way of doing things. maybe keep a contact lens in there longer than a day. But to me, a sea change is literally the paradigm shift. It's exactly the same thing. And you know what? We can be on the wave of this sea change, or we can just sit on our raft as this sea change floats by. Thank you guys. Appreciate you.
Oh, thank you, Mark. That was really Neveau. And you really covered a lot of ground. You went coast to coast on that one, so to speak. And I think you gave a lot of people some new things to think about. So thank you very much. We really appreciate that.
If you stop sharing, Mark, that would be great.
I'm going to do it right now. Bye.
Boom. There you go. Good job. All right. So, Mark, I just said that, I use the technique in a practice. And,
damn.
I have this person here that is, what I've learned to do is pre-treatment, take a picture, and then obviously you can see,
one eye,
put it in this eye. This is only after about 5 or 10 minutes. And then I always tease them, if they pay their copay, I won't let them leave with one eye up, one eye down. I'll put the drop in the other eye. And then here was a patient that, early on when I started doing it, that I did it in both eyes at the same time. You can see here. And then, I do this quite a bit. This one was actually today. I kind of jumped on the fact that she went with the Vivity IOL in both eyes, figuring that she'd probably want her eyelids raised. And she was ecstatic about, her eyelids going up. This is the subtenon's injection of steroids here. And here was another one just from today. Did the one eye, the right eye here, and then did both eyes. And, here's a little video that will play if the sound will come through. All right. And with a patient that we just put up Neek in, we did picture before, then we did one eye, her right eye, and then we did both eyes a little bit later. So she didn't have to look like a freak leaving here. She is going to use her copay. But just what are your thoughts here real quick? You were giving me a few thoughts. So go ahead and talk a little bit.
After I looked at the mirror, I definitely could see a difference. Plus, I can see better with my eyes more open like they are right now.
So, and then we just did this, 10 or 15 minutes ago? We just did one eye, waited a little bit, and did the other eye.
Yes.
So it worked pretty quickly.
Yes.
All right. Any other final comments?
I'm loving it.
All right. All right. Thank you. So that was a drop that I've been very surprised about, pleased about. You don't think a millimeter or two can make a difference, but it's patients coming in with better, say, neck problems, less headaches. Who knows what it is going to be. We think it's just an eyelid droop, but they might be tilting their head back or raising their eyebrows and trying to get those lids out of the way. So I would encourage, a lot of people to give it a shot out there.
Greg, have you seen any side effects? Because I've seen none.
Yeah, I haven't seen any side effects. Yeah. It's so low dosed.
Yeah. Oh, yeah. No, I mean, the one side effect is the eyes get more white. So.
Yeah, that's terrible, huh?
Yeah, isn't that horrible? So.
Yeah. So Marc, I want to say thank you. Great job with the Hackneyed and out with those, and in with the Neveau-eyed. Looking at the new eye care treatments and diagnosis, you certainly covered a broad range here and did a great job of it, and did it in an entertaining fashion too. So we appreciate your ability to kind of keep the audience attention. So thank you. So that will end the CE portion of this.